The last thing I want to do with you is abnormal findings. Now, I'm going to kind of go through this pretty fast. I think you guys can do this they're pretty self-explanatory. I usually have the students just do this part on their own. But let me just go through it pretty quickly with you guys. It's nothing, there are going to be questions on the test, but they're pretty easy compared to everything else. And I picked things that are pretty common that you've heard about, okay? Bone density problems, all right? Osteopenia is a smaller version of osteoporosis. When someone's got osteoporosis, that's irreversible. But you want to check someone often, like every couple of years, because if you could pick out osteopenia, which is where the start of osteoporosis is occurring, then we could stop the process and make it reversible. But once it becomes osteoporosis, whatever damage is done, we can't fix. We could stop further damage, but we can't fix whatever was done. So we want to try and get, identify the osteopenia before it goes into osteoporosis. And this is just, you see the pictures, they become more like styrofoam bones, and they have a lot more fractures that go on, more prone to fractures. Hip and vertebrae are the most common areas where they get the fractures. Okay, and that's where I said compression fractures. As women go through menopause, their estrogen goes away, and the estrogen tries to normally tone down the osteoclast activity. But once the estrogen goes away during menopause, now the osteoclasts get a little bit too happy, and they start chomping away a little bit more than usual, and that's why we see women going through osteoporosis a lot more than men do at that particular age. So what you want to do is put weight-bearing exercise. Put some, when they're walking, put weights on them, so that you're actually putting some kind of stress on the bones so that they can build up the bones with that. Okay. You ever hear of bisphosphonates, Fosfomax, Boniva? I see that quite often on the TV commercials. Basically, what that is that these are bisphosphonates, and these are going to decrease osteoclast activity. So, and they usually take it like once a month or once a week or so. They'll take it on this. So I want to ask you about these over here. Just an idea of what is osteoporosis, what's osteopenia. The treatments here are pretty for your, your own FYI type thing. Okay. Questions on that? And then I have pictures of all osteoporosis for yourself. There's compression fractures I was explaining to you about in the vertebrae, and that explains. You see the bulging of the belly goes out because the vertebrae kind of crunch, and the belly has no place to go, so all the intestines goes this way. So the grandma gets shorter, she gets a little protruding belly, and it's because of osteoporosis is one, and two, because of compression fractures due to the osteoporosis. Okay? Then you get fractures like this, and we have to do hip replacements of that. Okay? All right, arthritis. There's two types of arthritis. Osteoarthritis, and this is what we call a degenerative arthritis. This is wear and tear on the bones. Most commonly in people who are over 60 years old, but it's not that it's not common, someone who's in their 40s. Someone who does a lot of labor work is going to end up having this a lot sooner than people who wouldn't. Basically, the articular cartilage starts wearing down, and the spacing becomes less in between them. So if this is going to be, I think I drew this for you before, but if this is going to be our bones, all right, and we have this articular cartilage that's on the two ends of the bones, enough wearing and tearing on those articular cartilage starts making those articular cartilages bare, or those bones bare. So now you don't have cartilage to cartilage. That's nice when you have cartilage to cartilage, the articular cartilage is there, because all that pressure, you don't feel the pain, you don't feel the pain. But what happens when you start wearing down on this, once you make that cartilage go, you can't make it grow back. It doesn't have a good blood supply. So now you got bone to bone, and when you have bone to bone, that's going to cause a lot of pain. There's a lot of blood vessels there, there's a lot of nerves over there. But it can't find a happy medium. They feel the pressure there. If you let it sit there for days and months, sure, it'll grow properly. But every time you move it, it starts the bone, as you know, grows in wherever there's going to be more mechanical stress. So it has no place, it doesn't have any direction. Every time you're walking, it's like, whoa, it's like if you fractured your foot, every time you walk on it, sure, it's painful, but if you take away the pain, it has no place, it's got to be stable. Does that make sense? So the bone here is starting to grow, well, geez, it's going to grow this way, then it grows this way, then this way, then this way, then this way. It has no place to really go. It starts forming these bumps over here. These bumps are called osteophytes, or laymen call them spurs. Okay? And what happens here, it limits the range of motion because of the way that it comes out. Now you can't move it the way you're supposed to because now there's an osteophyte or a spur that's blocking where it's supposed to bend to. And now it can't bend all the way over there. So you can go in and shave those areas, but it's going to grow back because there's no articular cartilage there. So it comes to the point where the heck of it will just cut here, and just put a new joint there, a hip joint or a knee joint, because it's just too much. Okay. So what they get pain and deformity in the joints. Usually in their fingertips, it's usually the distal phalanges. You have a lot of bones, we call them phalanges, in your fingers. But the distal areas is where they usually get more. I'll show you pictures of that. They have these nodes, again, where spurs are occurring. Okay, you don't have to worry about the names of them. The osteophytes, as I talked about, are those spurs that start forming. And treatments for this is analgesic pain or pain medication, because you got to decrease that's maybe the reason why they can't move the joint in a certain area is because there's too much pain, in addition to the osteophytes are just blocking that area. So they'll get something called non-steroidal anti-inflammatory drugs. That's things like Motrin and ibuprofen and Aleve, all right? You can use aspirin. It's not this, but it's the same, it's analgesic medication. You could put some corticosteroid injections in there, and that'll decrease the inflammation that's occurring over here. All right, and worst case scenario, just cut them out and put new joints there. Okay. So here's a better picture of it. All this white area is going to be your articular cartilage, but then you're starting to form these spurs, or these osteophytes start growing up over here because it's now bone to bone. It's caused a lot of pain. All right, when it gets this bad over here, just say the heck with it. We'll shave this down and just put a piece of metal over there. Now, when someone needs to get a new knee replacement, that's what they usually do. And then in between, there's a piece of plastic there. This is the stuff that usually wears down. When someone has a knee replacement, and let's say 13 or 15 years later, they need a new hip replacement or new knee replacement. It's not because the metal wore down. It's because the plastic wore down, so they need a new piece of plastic in there. Okay? Rheumatoid arthritis is different than osteoarthritis. Rheumatoid arthritis is what we call an autoimmune disease, where for some reason, as we talked about with multiple sclerosis, okay, your body is fighting against itself. Why? We don't know. In people who have rheumatoid arthritis, they're producing antibodies to go against the joints in their bodies and attack it. Why? We don't know. All right, more females than males get autoimmune diseases, and this usually happens in young, middle-aged people, usually in their teens or their 20s, maybe up into their 30s. Osteoarthritis usually later on in life. And they usually have what we call nodules, which you'll learn about later when we deal with the immune system in ANP2. But it's where the antibodies and antigen complexes occur, and you get these nodules that might occur on there. The deformities don't usually happen at the distal phalanges, but more of the proximal phalanges. And when they point, they create this, you'll see the picture, kind of like, it looks like a swan neck. I can't really do it. I'll show you. But when they point, they do this. The treatment is similar to, in certain points, similar to osteoarthritis, where you have analgesics or these NSAIDs like ibuprofen. But then they also have this biologics. I don't know if you've heard of biologics. These are new that are just coming out in the past like even 5 or 10 years. And basically what they are is medications that fight against your immune system. And that could be good, that could be bad. I mean, it depends on how bad your rheumatoid arthritis is or any kind of autoimmune diseases. But if it fights against your immune system, then when you have the common cold, you're not going to be able to fight against that. So it has its pros and cons, but certain people are in really bad situation with rheumatoid arthritis or any of the other like lupus and stuff that are autoimmune diseases. So they take the pros and the cons and they weigh the risks and the benefits, and if they're a candidate, they'll take that. They can do corticosteroids, joint replacements. Don't worry about methotrexate, that's also there too. Gold salts is a pretty interesting one. I don't understand how the mechanism of it, but they use it as a last resort for rheumatoid arthritis. It's very expensive, as you can imagine. You're actually putting gold salts into the bloodstream. Gold, so it's very expensive. The problem is that when it goes into the kidney and the kidney needs to pee out that stuff, they kind of conglomerate all in the kidney and it starts causing kidney disease. They start getting really bad over there. So that causes a problem with the kidney. So, but if you know anyone in your family that have rheumatoid arthritis, talk to your doctor about these biologics and the gold salts if it's really bad, and see what his or her opinions are about those. All right. So just showing you, this is normal. Here's someone with rheumatoid arthritis, and here's osteoarthritis. So let's look at the two over here. Here's osteoarthritis, here's rheumatoid arthritis. Again, osteoarthritis, you're usually having joint deformities in the distal areas. Notice over here, they're pretty okay, closer in. But over here, these are pretty straight. But look at how bad these joints are over here, okay? Let me show you what it looks like here. If you look at here, see how this is osteoarthritis. The joints over here, they're kind of off. I mean, here's where the ring is, so you can see that. But they're kind of off-center. Whereas here, in rheumatoid arthritis, they're pretty straight up here. But the proximal joints look out of whack, right? And you can see over here, they're pretty straight over here. But look at how, see what I'm saying? How it is. And you can look at their fingertips and see what they have over here, okay? Osteoarthritis, they'll have these nodes over here that you can see. All right, more nodes. You don't have to worry about the names of them, they're up there. And rheumatoid arthritis, that's a boutonniere deformity, and that's like what we call a swan neck. Do you see how I mean like a swan neck? If I ask a person to point for me, and they have, it looks like osteoarthritis, or they look like arthritis, I get an idea of what they have by just looking at the point. Okay. And that's what the rheumatoid nodules look like when they have rheumatoid arthritis. I want to ask you that, but that's pretty bad. I've never seen them that bad. I usually see them very small. But if I showed you small ones, you won't remember them. So that's why I put them up there. All right, infections. Osteomyelitis. Osteomyelitis. Did I do osteomyelitis with you guys before? Why diabetics, they lose their toes, they get amputated? All right, it's because of this osteomyelitis thing that happens. So let me show you what goes on with this. Okay. All right. Osteomyelitis is basically osteo meaning bone, myelo meaning the bone marrow, itis means infection or inflammation of. We don't want an infection to go into the bone marrow because that's connected to blood vessels. Any infection that goes into the bone marrow will go into the blood vessels, will go into the blood, and the blood goes everywhere. We call that sepsis. It goes up to the brain, goes everywhere. If someone is septic, that's like the 11th killer in America, they will probably die with that. Okay, so we got to try to avoid that. So this is what happens. Osteomyelitis, a good example of this is, let's say, a diabetic. A diabetic, and I'm going to make this very quick for you guys to understand. A diabetic, they have a lot of glucose in their bloodstream. And the glucose is very sticky. What will happen here is that if they have a lot of glucose, it starts sticking to the inner lining of their blood vessels. And it usually hits the first area, the first blood vessel it usually hits first is going to be the small blood vessel, something called a microcirculation. The blood vessels that go to blood vessels, or the blood vessels that go to nerves. And the ones that usually happen first are the ones farthest away from the heart, which will be the toes and the feet. So now you have blood vessels that are going to get clogged going to nerves. So the nerves are not going to work. Does that make sense? All right. That's why what you could probably see some diabetics when they walk, they usually have a pot belly here. All right. A lot of diabetics. There's two types of diabetics, but the ones that's more common is the type 2 diabetes. They usually have a pot belly over here, so you don't see their feet. They don't like to bend down and tie shoes. Believe me, this is very common. So they usually are putting on slippers, slip-ons. Much easier for them to get around. Okay. So a lot of times they don't feel anything on the floor, so they'll say, the heck with it, I won't even put on slippers, okay? And what they do is when they're walking, they don't see the floor. They don't feel the floor, okay? So they tend to stomp a little bit more than other people. They'll usually walk around like this, and they're trying, what they're doing is as they're stomping on the floor, they're trying to feel where the floor is. They feel pressure, but they don't know if it's going on incline or decline or whatever. So they stomp a little bit more, okay? And you'll see them. If you know diabetic, I could almost catch people who are diabetics. You know what I'm saying? By the way they walk. So you could, I mean, severe cases. So they'll be stomping down. Now, if they step on a piece of glass, they aren't going to feel it. Do you agree? They're numb over there. It's basically you walking with slippers, or I'm sorry, you walking with socks. You feel pressure, but you don't feel what the ground feels like. You don't know if it's sandpaper. You don't know if it's smooth. Does that make sense? Okay? You just feel pressure. You know when you land on it. Okay? So what happens is they step on a piece of glass, and now they have a little bit of a problem. If this is their toe, right? You got it? Okay? That's their toe, and now they step on a piece of glass. Which means now, remember the function of skin, one of the functions is to protect from outside infections coming into your body. Well, now you stepped on a piece of glass, and now you have a hole here. They don't feel it, but an infection, outside on your skin, there's tons of bacteria. All right, you're loaded with bacteria inside your mouth, all over your body. But now it's able to go inside. And if you have bone over here, this infection is going to start eating away at this tissue, killing this tissue all around here, make it look black, make it look like a mummified prune, okay? You'll see it sometimes being very wet. We call it wet gangrene. And this bacteria starts going inside further and further. And if it goes into the bone and into the bone marrow, we don't like that, because this is now going to make the bacteria go into the bloodstream. When it goes into the bone marrow, we got osteomyelitis. And the only way to prevent the bacteria to go into the bloodstream is simply just cut this off before it gets up there. We amputate. This is not salvageable once it turns into that mummified prune. All right? So they have to amputate it. All right? So from the bone to the bone marrow to the blood, you become septic. Patients are septic, they go intensive care unit. And they're going to be on antibiotics. Once the amputation takes place, they're going to be on it for about 6 weeks to make sure it's all cleared out. All right? Question about osteomyelitis? Yeah.
If diabetics, if they don't feel if their feet are numb, how do they get like nerve pain and stuff like that?
That's a phenomenon we're not too sure about. Yeah, the nerve pain that's happening on it, we're not too sure why that actually happens. We know that, you see, if this is where it gets hurt, but over here the nerves are still good, it's still, we're going to get into nerves. And my idea of what it is you're still getting sensory nerves going this way. It's just cut off over here. So it doesn't know where it's coming from. So even if you cut off this toe, the idea that it's cut off, they still feel the sensation that it was cut. Because it's coming from no place. It's coming from that point over there. It's a confusing thing. Something we also call a phantom limb, which we'll get into a little bit later with that. Other questions about this? I definitely wanted to talk to you about this because diabetes is, I think it's like the 6th or 7th killer in America. So you've got to know this. This is what's coming into the doctor's offices, and this is what you're going to be taking care of. You're going to see this a lot. Okay? All right. Lyme's disease. Right? You've heard of Lyme disease. Lyme disease is a bacteria from a bite of a deer tick. Okay? Let's call myself. Okay? All right. Not a bite from a deer, but on the tick itself. And just because you have a tick on you doesn't mean that you have Lyme disease. It just means that you should be aware of the symptoms just in case you want to rule out any kind of Lyme disease later on. You usually get this bullseye rash, and I'll show you pictures of it. Not all the time, but you get this bullseye rash. You got like a target kind of rash. It's not itchy, and the weird thing is that it appears where you got bit, but then it goes away and it appears someplace else, and goes away and appears someplace else. You get fevers, fatigue, joint pain. It's very vague. It looks like symptoms of taking A&P1. You know what I'm saying? It's just very vague symptoms. All right? If it's untreated, it can go into your nerves, into your heart. But this is easy to fix. If you catch it early, when you have these things over here, you just take antibiotics and it's done. But if it's left untreated, it goes away, and then it doesn't really go away. It goes into the heart, it goes into the brain, goes into the nerves. That's where we have big problems. So it's being able to, it's being alert to, yes, I was in the woods, yes, I was playing on the ground, yes, I was laying on the ground and look at the fireworks, and I was in shorts, and maybe a tick went on my leg. I didn't realize that kind of stuff, and be aware of that. That, you know, if you did that, then go into the shower, look at your body all around to see if there's any tick there, okay? Because you don't want to have all this, all right? So treatment is just antibiotics. There's that bullseye kind of target rash that you get. It's not itchy. A lot of times it'll be in areas you haven't seen. That's why it's important to take your shirt off, show the back to your significant other, your mother, your father, see if you got any areas there. Because how often do you look at your back? How often do you look at your butt? You know what I'm saying? These are areas that can happen over there, okay? Or even the soles of your feet. How often, right? That's our little culprit, all right? Not him, but the tick that's on him. And that's about how small they are. I've had a tick on me before. A few times. I live in Sussex County. I mean, that's what happens, you know, where the woods are. It's just being aware of, you know, that you have it on there, and be aware that, you know, if you get fatigue or you get joint pain, say, hey, doc, you know, I did find a tick on me 2 weeks ago. It's like, oh, that's good. You know what I'm saying? You're just helping yourself with that, okay? But the idea is that when you take it off you, the bacteria is in the mouthpieces of this tick. So you just taking it off is not the full battle. You got to make sure that the mouthpiece comes off too. And there's a few places on the internet, which I don't know if they're really credible places that you can learn how to take them off. But they have these tools that you can take off at CVS. They show you how to take them off with a special tool you got to get underneath there to rip out over there. But you can see in New Jersey, Massachusetts, and all the New England over here, we're heavily involved with this. So just being aware. It's kind of like the misdiagnosis that we usually see in New England areas. Okay? And it kind of shows you how to remove the tick and whatnot. Okay? All right, medical surgical treatments and procedures. I'm not going to ask you anything on here, just an FYI, so I'm not even going to go through it. Okay? So don't worry about that.